today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. We'd like to thank our episode sponsor, Takeda Oncology, for their support of the Myeloma Crowd Radio Show program. Now, we're so fortunate in myeloma to have access to a wide number of new treatments. An increasing number of them are targeting BCMA, or B-cell maturation agents. The first antibody drug conjugate to target BCMA is BLENREP, which is also called belantamab mafodotin. And when we think about incorporating new drugs into our treatments, we also always will think about side effects, because I don't think there's a drug yet out there that is without side effects. Now, many myeloma patients are familiar with common side effects in myeloma therapy, like gastrointestinal issues or neuropathy or things like that. But with each new drug approval, which we're very grateful for, it comes with a new learning curve about what to expect. So on today's program, we'll be talking about a side effect called keratopathy, which is an eye condition. And we are fortunate to have with us two experts, one in myeloma and one in eye care. So Dr. Gasparetto and Dr. Newman, welcome to the program.
Thank you.
Thank you, Jenny.
Now, before we get started, I'd like to just give a very brief introduction for the two of you. Dr. Gasparetto performs laboratory and clinical research in the field of multiple myeloma. She works on developing immunotherapy approaches to treat myeloma, particularly in conjunction with stem cell transplant. So her ongoing laboratory research projects include the development of dendritic cell vaccines and antibody therapies, and her clinical studies include a recently approved trial involving vaccination with autologous dendritic cells and included with transplants. Her upcoming trials include new therapies for myeloma. She's an investigator that has used BLENREP in the clinic and has expertise with that. And with that, I want to introduce Dr. Gasparetto. And then Dr. Newman has been an optometrist in private practice since 1992 and was educated at Ohio State University and at Duke University. So we're thrilled to get the dual perspective, I think, because most myeloma patients haven't, there are some side effects I know with dexamethasone that can affect your eyes, but other than that, I think we haven't had a lot of expertise, or experience with this kind of thing. So, Dr. Gasparetto, let's start with you. Maybe you want to explain what BLENREP is and how it works.
Sure, of course. I would love to do that. So, BLENREP is a conjugated antibody. So, first of all, it targets a membrane, a protein that is overexpressed on myeloma cells. It's called the BCMA, the B-cell maturation antigen. And this protein is overexpressed in the myeloma cells specifically. In fact, is now elevated, is present at a very low level in healthy cells. So it is a very good target. It appears to be one of the newest targets that we have for myeloma, for treatment of myeloma. And so BLENREP was designed to target this particular protein, the BCMA protein, and is conjugated with what we call is linked with what we call a cytotoxic payload, is called mafodotin. And this payload is cytotoxic. The mafodotin disrupts the microtubule, and I don't want to be very complicated, but what it does, well, the antibody link binds to the BCMA protein, allows this mafodotin, this toxin, to be released inside the cell and cause the cell death, induce the cell death, so the myeloma cells will stop to grow, to proliferate, and eventually they go to apoptosis, the cell death. And of course it works also enhancing the immune system in different ways, but the major mechanism of action is linking to this protein that is overexpressed in the myeloma cells, and the release of the toxin, the mafodotin, into the cells, and then eventually the cells will die because the disruption of the microtubule networks. So it's very clever. It's not unique of this drug. We have other conjugated antibodies also available for other diseases, in fact, for other hematologic malignancies. But this is unique for myeloma.
Okay, wonderful. Thank you so much. I think everybody's wondering why this drug affects the eye. And you were kind of saying it's mouth odotin portion potentially.
Yeah.
But can you explain why it does?
Yeah. Yes, actually the mouth odotin is kind of what we call an off-target toxicity. So there is an accumulation of this toxin. And the eye, unfortunately, they compromised for this particular is actually is a characteristic of this particular linker, and so is the mouth odotin toxicity, and that's the reason why you don't see this type of eye toxicity with other anti-BCMA targeted therapies, like, you're familiar with the bispecific antibodies with the CAR T cell. So it's specific of this particular, another actually conjugated antibody, because the cytotoxic payload is one of the toxicity associated with this.
Interesting. And I know there's another antibody drug conjugate being developed in myeloma that seem to also have eye issues.
Yeah.
So maybe is it related to all antibody drug conjugates, or just kind of specifically the way this one works?
No, it's not. No, I mean, so there are several also approved, like brentuximab for lymphoma, that they don't cause the eye toxicity. So it's based on the particular type of linker associated with the antibody. And yes, you're correct that there was another conjugated antibody that was presented recently in a major congress, and there was eye toxicity, which was a little bit different than what we observed with this drug. So it's not unique. I mean, unfortunately, you can choose a different linker, I guess, but you may have different type of toxicity. I know that some are associated with severe peripheral neuropathy, which is something that we like to avoid. It comes with the myeloma territory and a lot of other drugs, very well, that carry the peripheral neuropathy. And so that's the reason why this particular linker was chosen to avoid other adverse events like excessive peripheral neuropathy in patients with myeloma. So it's new for the myeloma world, but it's not new for this type of drugs.
Yeah, interesting. So, I think it's something we just have to get used to, right? That, like, understanding what the effects are and how to manage it, things like that.
Yeah, exactly. Because, we get familiar with a lot of drugs, right, that we use in the myeloma, so we know that every drug has their own, like you mentioned at the beginning, their own toxicity. They have a toxicity kind of profile, and we know what was bad, the GI, the gastrointestinal toxicity, and the neuropathy, cardiovascular. So this is of this particular drug, and so we are learning how to manage and how to prepare patients and how to mitigate this toxicity as much as we can.
Yeah, absolutely. And the reason that I asked both of you to be on this show is because you work together with myeloma patients. So I think that's a wonderful partnership, and you can kind of share with us together what you've learned from your myeloma patients and on the eye, from in the eye clinic.
Yes.
So, Dr. Newman, maybe you can explain what is keratopathy, because this is a phrase that myeloma patients have never heard before, typically.
True.
And how and where does it affect the eye? So, let's start with that.
The term keratopathy itself is a rather generic term, just meaning pathology or disease of the cornea. And so a keratopathy could affect different layers of the cornea, a keratopathy could be caused by a bacteria, a virus, so you can have bacterial keratopathy, viral keratopathy, you can have dry eye keratopathy. So the term keratopathy itself is very generic, and it may affect, like I said, different layers of the cornea. The main layers of the cornea are the epithelium, the very top layer, which is regenerated very quickly. It's why when people get a little abrasion or scratch, by the next morning it's typically gone, because that layer, the cells regenerate very quickly. The stroma, or central layer of the cornea, that's what creates most of the thickness of the cornea, and that layer, if there is a keratopathy or something that affects the stroma, that's where you can have scarring and something that could cause permanent damage. Then you have what's called the endothelium, or very bottom layer of the cornea, the layer of the cornea that is against the fluid or aqueous humor that fills the eye, and that layer of the cornea is the pump for the cornea to keep it clear and make sure the fluid doesn't penetrate from the anterior chamber of the eye into the cornea. So there are certain things, conditions, pathologies that affect the endothelium, which result in a cloudy cornea because fluid gets in from the chamber of the eye into the cornea where it doesn't belong. Now, in the case of BLENREP keratopathy, it seems to affect just the epithelium, which is very good because, like I said, the epithelium regenerates very quickly, and so the effects are not permanent. They do not. It does not seem to cause any kind of scarring or effects to that stromal layer where you could have scarring, and so that is good. And that's now, however, the effects to the epithelium can certainly blur the vision and cause irritation and burning, sensitivity to light. So those things do happen with a keratopathy such as we see with the BLENREP. So that kind of gives you an idea of what's going on there.
And how do you diagnose keratopathy?
Yes, so to diagnose the keratopathy, we use what's called a slit lamp, and most people who've had an eye exam, would certainly have been in this instrument. But it's essentially a biomicroscope. It allows us to magnify the surface of the cornea, and usually I'm using about 25 to 30 times, or 30x, when I do these examinations, and we're able to see the cornea in detail, look for clarity, look for irregularities, and so that's the instrument we use to diagnose the keratopathy and to grade it and see how severe it is. That in combination, obviously, with looking at the patient's acuity, how their vision is, those are the two factors we look at.
Okay. Now, when you think, you talked a little bit about that there are different, severity levels or grades of keratopathy. Do all patients even know when they have keratopathy? Would they kind of recognize,
at the early
something's
stages,
going on with my eye?
Yeah, it's interesting. At the early stages, and if we're talking about BLENREP, this would be, say, after the first dose of BLENREP, we see the patients back at 3 weeks, and many times they will say, I'm seeing fine, my eyes feel normal. And I will look in the eye and I will see some keratopathy. So it just hasn't become symptomatic, but you can have keratopathy without symptoms. Again, it would be mild because as it gets worse, you do start to have symptoms. But yes, at the early stages, it can be asymptomatic but present.
Okay. And do all optometrists and ophthalmologists have experience with keratopathy? Like if I'm a myeloma patient visiting my regular eye doctor, will they know what to look for?
Right. Well, anyone looking, of course, yes, all eye care professionals have experience with many different keratopathies. Now, do they have experience with BLENREP keratopathy? The answer is probably not. I didn't have experience with it until I started seeing the patients. And fortunately, and they're coming out with more and more, but there are resources from GSK for eye care professionals to look at to have an idea of what they might see when they see these patients. And because the keratopathy is unique, it doesn't emulate any other condition like a bacteria or even a dry eye or all these keratopathies that we know from our training. This one doesn't look like it, so it doesn't. It's not going to ring a bell to anyone because it's new, and it was new to me. Now, I will say, once you've seen 3 or 4 patients and followed them for a few months, then you get a feel of how this affects the patient and what it looks like. And so yes, it is a unique pattern on the eye. When it starts, just to describe a little perhaps, often it starts as a ring-like pattern that spares the center of the cornea. So now we don't know why. Obviously the toxin gets to the eye probably through the tears, and why there's kind of an odd pattern of this, we don't really know. But that kind of spares the central vision. So the patient's seeing well, but yet they have some keratopathy, but it's in a ring-like fashion around the mid-peripheral cornea. So, and that kind of pattern is unique to this. There really aren't other things that you see this pattern with. And I mean, there are several different patterns I see in these patients, but that's one that I see quite often, and also kind of explains why a lot of these patients will come in, they feel fine, they still have good vision because it didn't affect the center. And then the ones where it affects the center, that's where the vision starts to become a bit blurry.
And can you describe or elaborate a little bit more on the symptoms? So there's this ring-like fashion that you may or may not have any difference in your vision. You could get some cloudiness, and you could get some. You mentioned kind of like irritation, eye irritation.
Yes.
Can you just elaborate on what other symptoms you could see?
Yeah, typically it's as they get. If they're past the mild keratopathy and say a more moderate, we would call it moderate keratopathy, then you do see the patients will often be a little sensitive to light. They'll describe eyes as burning a bit, and the blurriness, and those are the main symptoms. They really don't describe, say, a constant pain per se. We're not really seeing that. And which is good. The blurriness is certainly an impact, and there are, and I try to educate the patients at the very first we do a baseline visit. At the baseline visit, I do a complete check of the eye, obviously to see if they have any other underlying conditions or predisposing issues with their cornea that may make them a higher risk for a more severe keratopathy as they go on the medication. And at that visit, we definitely, and it had already been discussed with them at Dr. Gasparetto's office about the potential vision effects. And then I elaborate a little more, and I definitely let them know. And it is true, and patients should know this. Many of the patients, typically after the second dose, that's when I've tended to see the worst keratopathy, usually about a week or two after the second dose. So that when they come back for their 3-week visit, we see them every 3 weeks. After that second dose is when I tend to see the worst of the keratopathy. And a lot of times people they might not be able to drive for a bit because of the blurriness in their vision. But almost all our patients, again, in informing them ahead of time and letting them know, because of the response they've typically had on the myeloma side, they've been pretty accepting, and again, almost all of them have someone with them or a caregiver, so they're okay. If someone has to drive them for a bit, and so that does happen. And again, most. I don't know how much of this we want to describe now, but most commonly after the second dose, and then often the patients will have to miss a dose because of the eye findings. And what we find is as we go further out, they sort of reach a level, kind of steady state, if you will, with their vision. And where it's not what it was at baseline typically, but it's not what it was after that second dose. And they might have, some mild to moderate effects, but for the most part, most of them are able to resume their activities, and obviously also with the success of the medication with their myeloma, they're feeling better. And the thing they tell me, I mean, of course, I'm an eye doctor. I'm certainly not a myeloma specialist at all, but I ask them every time, well, how is this compared to what you've, and they all say, oh, well, the only thing about this medication is the eye effects. They're like, I don't get nauseous. I feel great. And so that's been a very positive thing overall. And I think, well, Dr. Gasparetto can comment if, obviously the feedback on her side is similar. I suspect it is, but I always ask them that, even though I'm focusing on their eyes, just to see how their overall frame of mind is and how they're, feeling systemically, and which tends to be quite good. And Dr. Gasparetto, can you just comment on that on your side compared to other treatments?
Yeah, before we do that, I kind of want to have you to walk us through this process, because you kind of referred to, every 3 weeks, and I just practically speaking, Dr. Gasparetto, can you first say how you consult with a patient who starts BLENREP, and then how does this process work? How do you connect with a Dr. Newman in your area?
Yeah, well, I feel very lucky and a pleasure to work with Dr. Newman. So our process is now quite easy. So I generally see a patient. I think the patient might benefit from initiation of BLENREP. So I do my part. I counsel the patient, explain in my way what keratopathy is and what can happen and what the potential side effects. And like Dr. Newman mentioned, is actually, other than that, is extremely well-tolerated drug. And so we talk about the risks and benefits, and then we set up, we submit to insurance, and we set up an initiation of therapy. And we try to send the patient to Dr. Newman the same day. Well, the baseline assessment takes a little bit longer, right, Mark? And then, and exactly. But then the subsequent visits are relatively short, of about 20 minutes. So we try to set up the appointment with Dr. Newman the same day of the infusion. So the patients go there first, then they come to our office with paperwork, and we got fax. Of course, we have the form that we have to complete, and then we make an assessment in clinic to determine if it's safe to continue the infusion or if we need to hold a dose, etc. So we work very well, because no matter what, the patient sees us and Dr. Newman the same time every 3 weeks. Even if the patient is skipping a dose, we like to have this continuity so we can actually see the improvement, the stabilization of the keratopathy, the symptoms, and improvement. So we work very well. So we do it on the same day, so they don't have to come to see us more than once every 3 weeks. And we check labs and make sure that everything else is okay, of course. So that works very well for us, and Dr. Newman is accommodating our patients phenomenally. I can't thank him enough, but they feel very reassured that we have, has overseen this particular toxicity together.
So if a myeloma patient, you have this wonderful partnership and collaboration.
Yeah.
If a patient shows up at any clinic, whether it's an academic center or a general oncology clinic, the patient doesn't necessarily have to find their own oncologist, right? I mean, you're either helping them find a ophthalmologist or optometrist that can help when you're doing this coordination, because that's very efficient, it sounds like, to go on the same day. Mm-hmm.
Oh, yeah. And, in order for us to prescribe BLENREP, we have to go through the training, the RAM program, right? It comes with this box, this particular toxicity, so we have to be trained, the prescribers, the facility, everybody. And so Glaxo have done a phenomenal job on coordinating all this process for us, and they are capable of identify eye care providers that can collaborate with the oncology closely in monitor and following these patients. So, I think that they're trying very hard to make, the system, simplify the system for our patients. So all oncology, all of us that are registered to prescribe and able to prescribe BLENREP, we have to go to the RAM programs, and we have to establish a relationship with our eye care provider before we start. So it becomes simple. So the patient does not have to find his or her own eye care provider. We will set it up for them. And we wanted the continuity. So, it's very important for us that Dr. Newman does the baseline assessment so he has an idea of what's going on, and also the continuity so he can determine the improvement throughout the treatment. And so it would be bad if the patient has a baseline assessment elsewhere. I believe, right, Mark? I think you have everything there, and so to follow the progress, the improvement, or the deterioration, because you see the patient from the very beginning.
Yes.
Mm-hmm. Yeah, great. I just wanted the patients to know that it's not on them to, if they want to take this drug.
No, they
try to figure all that out.
Exactly. No. And I think sometimes our job is to make sure that we have this partnership, so it's not difficult for the patient to be seen on the same day for both of us. So I have, a team of APPs, the advanced provider and PAs that help me in clinic, and so they're all registered. They can, follow the patients, and they help with the coordination of care. Absolutely.
Yeah, that's very nice. So because then you walk into the clinic for your next infusion, and the infusions for BLENREP are just every 3 weeks, right? I mean, that's why you're checking every 3 weeks, because exactly. Well, and also because I think we want to have the continuity. I think the keratopathy and looking all the data of the DREAM-2 study, which led the FDA to approve this drug for the treatment of patients with relapsed refractory myeloma. So we learned a lot, but Mark and I have also learned a lot treating our patients and following them longitudinally. And so it takes, it's a shorter period of time. It takes about 3 weeks for the visual acuity to improve, while the keratopathy takes longer. And so I think the 3 weeks is, for now, for the single agent, is the interval, but we're learning more about, can we actually go less frequently to mitigate the keratopathy, particularly in combination? Can we adjust the dosage? Can we go, rather than every 3 weeks, a little bit longer? And we're learning about that from the follow-up of some of these patients. Dr. Newman was talking about lots of patients, they have to hold therapy, but what is unique of this drug, what we see that even when we hold therapy, we see a durability. The responses remain stable, and actually in the DREAM-2 study, they were following longitudinally the patient responding. And what's interesting is some patients had to hold therapy for up to more than 3 cycles, and they still had an improvement of the response, which, is not very common otherwise. When you stop therapy,
So we were all very excited by this follow-up, this data, because I always reassure the patient and tell them, look, if you develop the keratopathy and other ocular symptoms, don't worry about, because even if we are missing a dose or two, you are not going to lose the response. And it's true. It's true. It's absolutely true.
It's been remarkable.
Right?
Yeah, we've had patients have to miss 9 weeks, and we even have one recently we're working with that has missed 12 weeks, and because of the keratopathy, but has still maintained their response. So
the response, absolutely.
Yeah.
So it's a very unique of this drug. Yeah. And, we were talking about other side effects before Dr. Newman was asking me that question. Yeah, I mean, you have about 20% that can develop some infusion-related reaction with the first infusion, but the majority is mild. About 20% or more patients developing low platelets, but we don't see that much, but is one of the potential side effects of this drug. Other than that, it's really well tolerated, and we don't need to use the dexamethasone as a single agent, and a lot of symptoms are related to the high-dose steroids. So it's very well tolerated, very well, and it's convenient because you have to come back to the doctor office every 3 weeks. You don't need the central line. It's 30 minutes infusion, so it's also very patient-friendly, convenient, so you don't want to affect the quality of life tremendously, right?
Yeah, absolutely. And this goes to show that also, it's been almost a year since it was approved, and I think there's so many things to learn when a new drug is approved. And sometimes you just don't understand that until you have some time with it. So now the both of you are seeing, what is it really like, and oh, okay, it's very well tolerated, and it's so that's really great.
We have patients that.
Oh, go ahead.
Oh, I was just going to say now we have a good handful that have been on it a year and have maintained excellent response, and I realize it has to continue to stand the test of time, and of course we'll see going forward. Hopefully these people will continue to do well, but again, these are people that had exhausted almost all their options, and now they're doing fantastic. So it's a great thing to see.
Yeah, wonderful.
I agree.
Dr. Gasparetto, in the myeloma patients that you've seen, how many patients, maybe you can kind of break it up into percentages, like with the patients you've seen, and Dr. Newman, you can comment on this too, like how severe, I think patients always are making this, you've both talked about this, about they're looking at how effective is this drug, and then what's the level of side effect, because as I'm picking and choosing therapies, those are the two things I mostly take into account. So maybe you want to break it up with just the patients that you've seen, how have they fared on the eye conditions?
Yeah. When I counsel a patient at the beginning of initiation of therapy, I always tell them, look, the chance you developing keratopathy is very high. It's a little bit over 70%. I always talk about the percentage it can help patients. And like we mentioned earlier, not necessarily all patients with keratopathy will have symptoms. But I would say that half of patients, 50% of patients, will develop some decrease of the visual acuity. And then about 20-30% will have the blurred vision. So I always remember these numbers from the DREAM2 study, and it's really reflecting what we see in clinic. And always I tell them, if you look by keratopathy, the grade, we can divide it by grade 1, 2, 3, and 4, with 4 being the worst. The percentage of patients developing the worst, the grade 4, is less than 1%. And with the majority of patients developing, I would say between grade 2 and 3, if you break it by number, I would say that 20% will be grade 2 and 40% grade 3. And like Dr. Newman said before, we hold the therapy, we make some adjustments if it's necessary until, we wait for the improvement. And then when we restart the drug, is more kind of a stabilization of their, mild keratopathy, I want to say. And again, I don't think I had any patient that I had to completely interrupt because the keratopathy. I had a couple of patients with Mark that were more bothered, and I guess was the underlying keratopathy, but the blurry vision was bothering them. I had one patient that didn't want to continue therapy because the blurriness, the blurry vision. The decreased visual acuity seems to improve faster, right? And at least, from my point of view, from the DREAM 2, and Mark can say a little bit more about that, but it looks like they have, and we had a couple of patients, right, Mark, that they actually, particularly one recently that had a severe decrease of visual acuity, but in the study, there were no patients, like you mentioned earlier, that develop blindness, that they have they didn't have an improvement of the visual acuity, correct?
Yes.
Yeah. So
yeah, and definitely, as you've said, they do tend to. It's after that initial burst. I mean, after the second dose is when we kind of see the worst effects, and then they, like we've discussed, they might have a dose pause, and then things improve, and we get to a level where, let's just say, to put an example that people could understand, like when someone comes to me for a baseline and their vision's 20/20, and say they have the first dose, and most of the time they'll come back in, they'll say they're doing pretty well, and they might have some keratopathy that's asymptomatic, and I tell them about it. Then they go have their second dose, and I tell them before they go for it that, it's after the second dose that we tend to see most of the effects, just so they're prepared. Then they'll come back, and they might be, let's say, 20/70 or 20/80, which is significant. And they will say, yes, my vision's blurry. You told me that might happen. And then that level would make it so they would have a pause in their treatment. Then they might come back 3 weeks later. They may still be at that level, or they may improve to, say, about 20/30, which at that level they'll have a repeat dose. If they're still at 20/60, 20/70, 20/80, they might wait, and then it'd be a 6-week pause, and then typically they'll come back and they're at that 20/25, 20/30. And some people return to 20/20. The one caveat to that, which we haven't discussed yet, is that that's what we call the best corrected vision. So someone might have a certain prescription when they come in here, or no prescription, and be 20/20. But what the BLENREP, part of the BLENREP keratopathy is, it does kind of alter the actual prescription to see better. So I put them in my machine that we use when people come to the eye doctor and they look through the lenses, and we generate what is the best vision we can get for this patient today. So it might be back to 20/20 or 20/25, but of course they can't leave the office with that, because if we did put that in a pair of glasses, it might work for a week, and then what we notice is each time we see them, the number or prescription to correct their vision is different. And that's something I want to make sure people are aware of. So it's still reassuring to the patient that they look through the machine and they're like, oh, I can see now, but I can't see without it. And unfortunately, like I just said, it's not something, they will ask, oh, well, can you give me glasses like that? And then I could see. And of course, we say, yes, we could, but it might only work for a week or so we just wouldn't do it. So I hope that additional information helps, too, because we look at what's called the best possible vision, which is not how they're seeing day to day, because they don't have that prescription to wear. But most people stabilize to, let's just say between, even 20/20 to 20/30, 20/40, which is still vision that you can drive with and do most of your activities, again, somewhere in the, 2 to 3 month time frame after starting the treatment.
Mm-hmm. And okay, that's very helpful. And Dr. Gasparetto, when you do hold the drug, and you just, like what Dr. Newman said, you just hold it, and then you say, okay, let's check you next time in 3 weeks, and let's check you next time in 3 weeks. And that's how you're looking at it too, from a myeloma specialist point of view, and then you're watching your labs and everything?
Yeah, when they come to clinic, we check their myeloma labs, even if it's only 3 weeks, and their regular labs, particularly, as I mentioned, for potential low platelets count and other labs abnormality. And so we monitor the myeloma, of course, and so we know every 3 weeks we look for the markers of their myeloma, and we know if the patient, is old in therapy and is progressing. But as I say, it doesn't happen, particularly, patients, they seem to respond immediately after the first dose, after the second dose. And so, when they develop the keratopathy, they already have achieved the response. And when we hold the drug, we don't lose that response. So that is, as I mentioned earlier, very unique. And then if they develop, more than a mild keratopathy, we make a determination if there is now a complete improvement, a complete resolution. Sometimes we decrease the dose. We go from 2.5 milligram to 1.9. And that kind of helps. And that's the reason why the future clinical trial, the combination are assessing, different dosage and also, longer interval between the dosage. But it's too soon to say. I think right now it works in this way, and we have longer follow-up of the patients in the DREAM2 study, which are very encouraging, showing the durability of the responses.
Great. And how frequently do you have to hold the drug? I mean, what % of patients?
I think, I think that about what I can say that probably 50%, half of the patient will end up to require holding the dose even more, and then I would say that maybe 30%, and if you look at the data of the DREAM study, they will require a dose reduction. But the discontinuation of the permanent discontinuation of the drug is actually very low. So it happened, I believe it's less than 10%. So in the study, so and in my clinic, so we had patients that they had to discontinue because they lost the response, but because the visual problem, as I say, I think a couple of patients for the blurry vision, but not because they were not responding or because they had severe keratopathy, was just they didn't like it. They really didn't like it. So the permanent discontinuation of the drug is actually very low. But I would say that more than half of the patient will require some dose interruption at a certain point, absolutely, for even more than 3 doses continuing. Like we say in our clinic, we had a patient holding for 12 weeks, and so but still maintaining the response, which is that's
very remarkable,
right?
Yeah, it means it's a potent thing that it works.
And maybe that's the reason why we're looking. Maybe we don't need it as often in the future. I don't know. I mean, but we don't want to lose the responses yet. So we don't want to jump into conclusion and say, okay, everybody is going to receive the drug less often because we don't have the data. So for now, we have to continue this dose, this interval, because we have all the data. And then eventually in the future, we may learn more from clinical studies and see if, we can mitigate the toxicity with the different intervals.
To me, this just says you need to have frequent communications and be really open with your doctor about what's happening with
Yeah.
you, and then I'm sure Dr. Newman, you're giving her suggestions too about, because it sounds like the patient takes a report back to their physician, so you can really see what's happening from him. Mm-hmm.
Right. There's a pretty formalized report. I mean, it's a brief report, but it has all the critical information, and then I often add some information to try to let Dr. Gasparetto and her team know how things are trending. You know, perhaps someone is stable and in a dose hold, but it's looking a little better, but they're still in the category where they have to wait 3 more weeks for us to reevaluate. But we communicate immediately. I always give the patient a copy of the report as well, just in case fax, email, whatever doesn't quite get to the right person. They have it in their hands, so there's no delay. Yeah, and for us, of course, a lot of our patients do come from out of town or from far away, so being able to time everything on the same day definitely helps. And I'd imagine a lot of your other patients around the country here that might be listening to this, also that go to, say, a major medical center, they may have to travel some distance. So being able to coordinate it such that we have the eye exam in the morning, and then they see their oncologist, 2 or 3 hours later, and having that achieved in one day is certainly the ideal for this, for following patients on this medicine.
Mm-hmm. Yeah, and then you're not in a weekly dose, or it has its advantages for sure. So when you hold the dose, or you lower the prescription amount, let's talk about just holding the dose for a minute. When patients go back on, so like they're sustaining responses, and this is clearly, and I kind of want patients to know that what you talked about, how it works in the beginning, is very different from how other BCMA-targeted therapies work, because this is almost like your immune system's helping deliver this toxic payload, but your immune system is not like the working tool here to kill the myeloma, right?
Well, yes and no. I think the antibody works linking to the BCMA and delivering the payload, the cytotoxic payload, but also enhance the immunomediated, there is an enhancement of the immune system. So we kind of BLENREP recruits and activate other cells of the immune system, inducing, cell death of the myeloma in different way. And so this is immunotherapy. I think it works directly linking to the BCMA, but also immunomediated, inducing cell death through the immune system. Absolutely.
Oh, okay. That's great. I didn't know that.
Yeah. I would say that it has multiple mechanisms of action, absolutely.
Okay, that's wonderful. That makes it more effective. When you put patients back on, do the same symptoms come back? Do you decide to lower the dose when you put patients back on? How do you do that?
So, if a patient develops just grade 2 keratopathy, which is kind of a mild keratopathy, we generally we can restart the drug at the same dose with the prompt improvement, the resolution of the keratopathy. If a patient develops more severe, like grade 3 keratopathy, we tend to decrease the dosage at time of reinitiation of drug. So
okay, that makes sense.
So we generally tend to restart at the lower dosage for grade 3. For grade 4, which we don't see very much, and that's good, you could resume a reduced dose when there is a resolution and improvement to a grade 1 or better, but sometimes when you have a grade 4, then is when you may want to discontinue the drug. But as I say, we don't see it very often. We don't see this type of, severe keratopathy, the corneal defect, the ulceration very much. And so, but yeah, if a patient develops grade 3, which is more kind of moderate, we tend to resume at a lower dosage, and we don't lose the efficacy, we don't lose the effectiveness of the drug.
Yeah, okay, that's great. Dr. Newman, so I just want to reemphasize, because we talked about this at the beginning of the program, because this is the top layer of the eye, this drug cannot make a patient go blind, right? I just want you to be really obvious about that.
Well, it has not. I mean, could I say 100% that couldn't happen? I guess I really can't. But everybody who's been on it so far, and even in those studies, the Dream 2 study and the 30 patients or so that I've seen in the last year, I've seen no effects beyond the epithelium. So yeah, it just doesn't seem to be there. It seems to only affect the epithelium, in which case, yes, someone might have very blurry vision, and they might have to be off the medicine for 3 months even, or 4 months, sometimes up to 6 months for it to fully go away, but they will return to their pre-medication baseline. So yes, yeah, and I try to reassure the patients that, we've not seen anyone with permanent damage from this, no damage to what we call that stromal layer where you could have scarring. So we have just not seen that, and no, I've not seen it reported anywhere at this point.
Okay, great. I think that's the most essential question that patients want answered. Yeah. Right? I mean, that's what we all think about.
Yes, that is the most important conversation, yes. No, I think I totally agree. We were commenting earlier that is what the patient needs to know from the very beginning when we start the drug. And so having me counseling and then Dr. Newman counseling them is very important from our different perspectives.
Yeah, absolutely. Dr. Newman, is there anything else that provides relief? Like, let's say you have itchy eyes or kind of that burning that you were talking about. Are there other things like drops or things like that patients can use?
Right. Well,
I was reading that steroid drops don't really work, right?
Right. Yeah. And again, steroids typically for inflammatory type condition when used on the cornea, and this is not an inflammatory condition. It's a toxic condition due to the medication. So things that dilute the medicine, so to speak, on the eye, like the artificial tears. We use preservative-free artificial tears, and actually those are, which is great, they're provided by GSK. They provide the patients, and that way they don't have a cost in that aspect of their treatment, which is definitely a big incentive to compliance. So because the drops can get expensive or it's another expense that the person would have. So it's wonderful that they supply those. And the protocol for the treatment advises 4 times a day, and we have people. We start people with 4 times a day. If they start to develop keratopathy, we go to like every 2 hours on those drops. And sometimes also I will add ointment at night, which a lot of patients have found that comforting and helpful. Cool compresses sometimes give people a little symptomatic relief. But yes, the steroids, I've not prescribed them for anyone. And yes, you're correct. In the initial studies, it was shown to be equivocal, basically not effective.
And you mentioned some other eye conditions that you do this baseline and you see if somebody would be a good fit. Are there other eye conditions that somebody can have that might be a problem for somebody starting?
Right.
For somebody starting
on I would mention that people who've had a history of prior LASIK vision correction. We have, I think, 4 patients that I've seen on BLENREP that have had prior LASIK. And those patients, their corneas tend to be, or in these particular ones, but in general, they tend to be a bit drier. And so they're going to be a little more prone to the BLENREP keratopathy. And indeed, in these patients, it was a little worse initially than what we would see with patients who had not had LASIK. So I do give those patients a little extra counseling, like, hey, this could be worse for you than for some other people. But actually, they've all, I mean, they're still on the treatment. They're doing well, and their keratopathy, although it was a little more severe, again, not to this severe stage, but more significant, say, after the second dose than someone who didn't have LASIK, they still have recovered to a pretty good steady state, after, let's say, 3 months or so. So, and the other kind of red flag or thing I watch for is people with significant dry eye at baseline, because those people, their epithelium is already disrupted a bit because they've had cells that have dried up and died. So the patients will be familiar when they go to the eye doctor with the eye doctor putting a yellow dye in the eye. And that yellow dye called fluorescein, it will stain where the dead cells, in other words, the space left by a dead cell. So it shows up when I look at it under a blue light. We'll see this peppering on the cornea where all the dead cells are. And so when we see that at baseline, that makes us more concerned that this patient may develop, a little more keratopathy than someone who doesn't have this. But again, and we've seen patients both with the LASIK and dry eye at baseline, but they've still done well. They've just maybe had their level of blurriness or level of symptoms was definitely a little bit higher as they've gone through this than someone who did not have those predisposing factors.
Okay, so interesting. And what about patients with have contact lenses? Right,
yeah, contact lenses you're not supposed to wear contacts while you're on this treatment. So so anyone who is truthfully, actually, I've not had anyone yet of the 30 or so patients I've seen that was a contact wearer. so I didn't have to take the contacts away from them. But yeah, it is, if you read in the BLENREP literature, it specifically states not to wear contacts while you're on BLENREP, which makes sense because that lens could be a reservoir for the BLENREP that's coming through to the eye and perhaps increase contact time to the cornea and make things worse. So yeah, we would tell patients, they should not wear their contacts while they're on this treatment.
Okay, that's good to know. Okay, I'm not leaving hardly any time for caller questions. If you have a question for Dr. Gasparetto and Dr. Newman, you can call 347-637-2631 and press 1 on your keypad. Okay, I have other questions for you, Dr. Gasparetto, while we're seeing if you have any other caller questions. If you combine BLENREP with other myeloma therapies, I know sometimes we've seen this like in selinexor, maybe you combine it with Velcade and it actually makes your neuropathy better. Or if you combine BLENREP with other types of myeloma therapies, which is perhaps where treatment will head next for BLENREP, do you see anything making things better or worse? Or
So, when we combine agent drugs together with a different mechanism of action, we see an increased rate of response, right, with all the drugs. That's the reason why we treat patients with a cocktail to increase the effectiveness and also to decrease the chance, the rate of resistance. And so we have all this combination that they become more potent, more effective. And so there are actually a lot of different combinations under evaluation, the different, DREAM, they have DREAM studies, they have a different name, and different number based on the different combination that the BLENREP has been testing with. And we had some preliminary results presented with bortezomib, with pomalidomide. And I think what is going to be interesting, like we mentioned earlier, when it's given in combination, and so maybe more effective because the synergistic, the dual effectiveness, maybe we don't need to give the BLENREP every 3 weeks. Maybe we can give it less often and have less of the eye toxicity. And so there are studies ongoing to evaluate different dosage, lower dosage in combination, longer intervals. And so we are all excited about that. And then, of course, when it was tested, very heavily pretreated population and approved for patients with the really very resistant disease. And so then the drugs are going earlier into the line of therapy. And so we're going to see BLENREP become very more effective when it's given earlier on during the course of the disease. So I think we're all waiting for different combination and the evolution of this very important drug that just entered the myeloma world and is changing, like Dr. Newman was saying, for his perspective and my perspective. I mean, it's changing the dynamic of the disease. Some of these patients didn't have any other options, but we don't want to keep it just for those patients. We want to just bring it earlier on and use it earlier to target. The BCMA is the new target for myeloma, so we do have a lot of new agent coming up. And the only other thing that while Dr. Newman is on the phone, we discussed together, if we have a patient with history with cataracts, maybe it's better to do the surgery before the cataract removal, before we start BLENREP, right? Because right, we talk about that. Just
so we've had a few patients where we had and they were able to have their surgery and then start the treatment because of the compromise to the cornea with the keratopathy. They would not be able to have surgery while on the BLENREP. So, that was a great point to bring up, so people kind of know that. Yes.
Exactly.
Yeah, really important.
Unfortunately, we see a lot of patients developing even earlier cataracts because the high-dose steroids that we use. And so that's very important. And, in the study, we had a lot of patients older than 70, and the rate of keratopathy was very similar to the younger population. So it's actually a very well tolerated, even in a more frail and elderly population of patients. But because they start with a already decreased visual acuity, sometimes we have to be cautious about that. And the cataract surgery is also part of something, the discussion, I think.
Yes.
Great.
Yeah, and it's ideal because that helps. That helps maximize their acuity going into the treatment.
Exactly.
So,
Exactly.
Wonderful. Well, I have one final question for both of you. Dr. Newman, do you have any other comments from an eye specialist perspective? You both said that this is a very well-tolerated drug, and Dr. Newman, you're asking patients, how they're doing with their myeloma in addition. But do you have any other thoughts that you'd like to share?
Yeah, just that people, if it's proposed to them, I don't think they should be afraid of it. There just haven't been any permanent negative effects to the vision, even though you'll have some temporary effects, or perhaps a low grade of effect that will stay with you through the treatment. But the benefit of the treatment, at least what we've seen so far, has definitely outweighed for again almost all the patients we've seen, outweighed the side effect to the vision.
Okay, wonderful. Thank you. We're so grateful that you're on this show, and I'll thank you both in a second. But Dr. Gasparetto, I know that many myeloma patients need all available drugs on the table when they're considering care. So do you just want to close with how and when you use BLENREP in the clinic?
Yes. So, it's becoming a very important drug in our clinic, in the community. Is the, we have, in addition to BLENREP, we had other drugs in the development or recently approved with the same targets, the BCMA targets. So we are definitely we're trying to figure out, can we use all these drugs and what is the best sequence, right? And particularly with the CAR-T cell that was recently approved. But the problem with the CAR-T cell is a very important procedure, drug, if we want to call it drug. You're very familiar with the CAR-T cell. The problem that we have with the CAR-T cell that it has to be done in an academic center or a large hospital. Patients, they have to be in very good performance status, be able to manage the toxicity of the CAR-T cell, and also, so what I'm trying to say that is a phenomenal addition to our pool of drugs that we have available for this complex disease, but we cannot bring it to all patients, right? It's not there available for all patients, particularly, myeloma remains a disease of the older population, if you want to say. I'm always surprised because in my clinic I see a lot of young patients, but then when you read, the statistic remains more prevalent in the older population. And so you're not going to be able to do the CAR-T cell in the majority of patients older than 70. You could, there are some patients, they're very good performance status, but not necessarily, it's not available, it's not on the shelves available for everybody. So that's the reason why this drug is going to be very important for these more frail population of patients, patients that they don't have access to the academia, and we're going to see, what's going to happen in different combinations. But it's really changed our treatment over the last year since approval, because I have to say that it is effective, it works, and we are learning how to manage the toxicity, and so I like this drug. I really do. I think is one of the new drugs that really has impact on the course of the disease. And I've been doing this now for a long time, for 20 years. So I had the introduction of all the major drugs for myeloma, and from the thalidomide to the lenalidomide, the bortezomib, and I have to say that this is another big ammunition that we have to fight the disease, prolonging probably the life of many patients. It works. And so I'm glad I'm here with Dr. Newman, because I think if we are able to mitigate the toxicity and help patients to be able to tolerate the drug, and it seems like we don't have a lot of issues. As soon as you learn to manage the toxicity, I think it's obvious that it's doable and is feasible for a lot of patients, including the older patients, the more frail patients, which, sometimes we can't treat in the same way because they're not going to be able to tolerate therapy, right? So this is very important drug also for that population of patients, right? So I'm very excited to continue to treat patients with myeloma and having more options available.
Yeah, I think it's really stunning what's happening, and I'm grateful for all these new approvals and for the companies that are making them possible, because like what you're saying, not one therapy is the right thing for every single patient.
For everybody, exactly.
Yeah,
you have to tailor, you have to to adjust therapy based on the individual, the age, the type of myeloma, the other medical issues. And so we need to have more and more options so we can apply to all our patients. Again, not all patients that we're treating with BLENREP could be eligible for the CAR-T cell, and the CAR-T cell might not have worked, for them. So it's another option. And my hope is that we can sequence this drug, including the CAR-T cell, go early and then sequence and being able to reuse the same targets with a different drug. And we do have other drugs in myeloma with the same targets, right?
Yeah, and they can be reused, in different combinations or after a different period of time or whatnot.
Exactly. So we just have to wait for the data to become more mature, and we have a longer follow-up of the DREAM2. We're learning a lot, and very exciting. I mean, and I know one of the things that is very difficult is to counsel the patient. So I'm glad that Mark mentioned about, the fact that all these symptoms are reversible, because it's a new world for us. It's a new toxicity.
Right. We just have to gain experience. Well, I'm just so grateful for the both of you that you are willing to take your time to share all that, your experience with patients, because you not only have the academic side in the studies, but you have this practical real-world experience as well. Of patients coming to your clinics every day who are taking this treatment. So we're just so thankful that you took the time to share your experience with us.
Absolutely, anytime.
Yeah, our pleasure. Yeah, our pleasure.
Yeah.
Well, thank you, and keep up the great work. Patients will continue to come to you and be glad that they are. So we're thankful for you both. And we're thankful for our audience, and thank you for listening to Myeloma Crowd Radio. We invite you to join us next time to learn more about what's happening in myeloma research and what it means for you.
Hey guys, it is Ryan. I'm not sure if you know this about me, but I'm a bit of a fun fanatic when I can. I like to work, but I like fun too. It's a thing. And now the truth is out there. I can tell you about my favorite place to have fun. Chumba Casino. They have hundreds of social casino style games to choose from, with new games released each week. You can play for free anytime, anywhere. And each day brings a new chance to collect daily bonuses. So join me in the fun. Sign up now at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.